Good afternoon, everyone. Welcome to the sixth session of foundation course in palliative nursing. Today we are going to study about communication, bad news, and collision. We have faculty Ms. Rajika Kurup here. She has an MSc in applied physiology with specialization in clinical psychology and also holds PG in diplomatic in geriatric counseling and PG diploma in yogi therapy. Previously, she worked with Nirbhaya, which is a shelter home for protection of sex crime victims, presently managed by Nirbhaya Cell of Social Justice Department, and also worked as a therapist for children with neurodevelopment disorders. She is currently working with Pallium India as a senior psychologist for more than 1 year. Welcome, Rajika. Okay.
Thank you, Sankeet. Okay, so I guess in the previous session, you discussed about communication and how to go about, how to do a proper communication and all. So we'll just start from there, from where we stop. Sankeet, can you please share these slides? Okay. Yeah, so this slide has been prepared by Dr. Priyadarshini Kulkarni. Actually, she is a consultant of palliative medicine in Pune. So she's the one who has prepared this presentation. So I'm just taking that from her. Okay. She is also currently working with us for taking sessions and all. So yeah, next. I know that it's a pretty lazy time, for taking sessions, and especially when we are taking sessions like, communication and breaking the bad news and all, it's pretty lagging one. But I hope you bear with me for this session. And I would like to see at least a few faces if that is possible. If not, at least turn on the mic at times when I'm asking questions and all. So I'm basically looking forward for an interactive session, okay? So yeah, so basically in the previous session, I know that you went through skills needed for communication, what are the skills, how to go about communication, and also basically it's thinking, listening, speaking, and how the non-verbal cues affect communication skills and all. So moving on. So why do we think we need proper medical communication? Any one of you? Why? Yes.
Proper understanding.
For proper understanding. Okay. So why is it that necessary to learn about this? To learn how to break the bad news, how to give a proper communication regarding regarding the bad news.
लिंक नहीं हो रहा है वो किया सर तो आगे नहीं हो रहा है उसको भी भेजा है
Anyone would like to give you can use a chat box, okay? Please use a chat box for answering, to have understanding, convey correct messages to support patients and family, okay? Thank you so much, Rita, Lily. Thank you, Shante. Okay, so basically, when it comes to a medical communication, where we have to talk about the prognosis, diagnosis, or it might be breaking the bad news, it kind of enhances the therapeutic nature of the medical encounter. So there is this, most of the time the patient, they don't have any idea of what they are actually going through. Okay, they might know that, okay, you are having cancer, but they don't know what kind of a prognosis they are at what stage they are at. And there might be a lot of might be a lot of uncertainty of what I'm going through. There might be a lot of a lot of less clarity in how they perceive the disease. So in order to close this gap, we need this medical communication. That is why we need this medical communication. So in order to improve patient satisfaction, to prevent inappropriate hope and guilt. So most of the time, what we might unknowingly give false hope. Everything might get better, when the things are not on the right track, when things are deteriorating, when the health condition is deteriorating, when the medical condition is deteriorating, we still might say, yeah, you might get well soon, or this might get better. So in order to prevent such giving inappropriate hope and false hope, this communication is very important. Also, guilt, to prevent guilt as in when it comes to the caregivers most of the time have a lot of thoughts regarding like I should have done this, I should have done that, maybe I should do this, I should take my father to a much better medical facility where there is like proper much better medical services. I should take my father to a better hospital. So there might be a lot of should haves. So to prevent such should haves, to prevent such false hope, communication is important. To prevent, and most importantly, to prevent conspiracy of silence. What do you think is the meaning of conspiracy of silence? Any idea? Any idea? Does anybody has any idea of what is conspiracy of silence? See, if I am the patient, okay, and I know what I'm going through. So I'm a patient, I'm having a CA breast, and I have reached a point where maybe the medical side cannot take further, and I'm in a deteriorating condition. And I know the fact that my days are, like it's less, it's going to end soon. At the same time, I'm not sharing this information with my caregivers. Same with the caregivers. The caregivers know for a fact that my condition is deteriorating, and I might pass away soon. But this information is also not completely told, or not shared amongst the patient and the caregiver. Okay, so both are kind of, they know what they are going through. The patient knows what the patient is going through. The days are less, and the caregiver also has an idea that okay, the days are very countable. There is not much time for the patient, but we are not sharing this information, and we are like suffering in silence. Both of the patient as well as the caregiver is suffering, but they are not sharing this information. So this is basically the conspiracy of silence. That is, both the parties, that is the patient as well as the caregiver, both of them know like what they are going through, like what the current condition is, but they are not willing to say it out loudly or open up about it or share amongst themselves. So, and both of them suffer alone. Like I suffer alone, and as well as a caregiver. It might be my mother, it might be my spouse, it could be anybody, and they also suffer in silence and alone because we are not sharing this information amongst ourselves. So that is conspiracy of silence. So in order to prevent conspiracy of silence, again, medical communication is important. So these are the major aims of having a proper medical communication. So what are the impact of communication? What happens if the communication is not taken forward properly, and what happens if the communication is taken forward improperly? Okay, so if the information is not passed in a proper way, for example, I'm a psychologist, okay, or let it be you might be a nurse, you might be a doctor, you might be any other professional working in a hospital. Okay, so I'm walking through a corridor and I'm doing a lot of work. I'm busy taking a call, I'm busy talking to someone else, and I may be busy doing a lot of things, and in between this patient comes and the report is in my hand, and suddenly say to him that okay, you are having so and so cancer, you're in the 5th stage. I think that you might your days are countable, you may not live you just have like maybe 3 months more. If suddenly I'm breaking this news to them in a sudden in a way that it's like shattering their world, that their world comes shattering down. So the emotions, negative emotions like shock, disbelief, numbness, guilt, etc., comes in the patient and the family. So if the communication is not done in a proper way, it can lead to a range of negative emotions like shock, disbelief, numbness, guilt, etc., in the patient as well as the family members. So and if the communication is done in a proper way, which we'll be dealing later, like how to go about the communication. And if the communication is done properly, which can lead to a stronger trusting relationship that can help in better patient care. So they kind of develop a trust towards the professional. It could be a psychologist, it could be a nurse, it could be a doctor. So they kind of develop this trust in between the doctor or whoever the professional is, as well as a patient and the family members. So this is just an example of how a bad communication is. Doctor, the patient comes to the doctor. Okay, I hope you can read the slides. The patient comes to the doctor and says, "Doctor, I don't feel too good." And immediately the doctor replies, "You have not followed my instructions, I can see." Immediately the doctor is putting the blame onto the patient. And what do you think the patient might feel if at all a doctor says like this? I'm going to a doctor with a lot of hope and a lot of solution, expecting a lot of solution. And when I do that, and the doctor immediately says, you are not following my instructions, and that's why you're feeling so and so. That's why you're not feeling great. So what do you think? What might be the impact that is put upon in a patient? See, this is going to be a very interactive session. I would like at least one or two answers. I know that most of you might be like caught up somewhere in work and all, but unmute yourself, those who can. Yeah.
Patient will have the negative impact.
Exactly. Thank you so much. The others can actually put in the chat box as well. Yeah, they might feel bad. They might feel. See, doctor, especially if it comes from a doctor or a nurse. Okay, see, we see up to them as someone who can save us, who not at least save, at least with some hope. We are seeing them, right? And we are like telling them, so one of the most difficult part of what we are going through. See, I'm having so much headache, or I'm not able to sleep properly. I don't feel good. And the doctor immediately says that is because you're not following my instruction. In just a sentence, the doctor is cutting down the communication, is just breaking down. And the patient himself won't feel like opening up much about his physical or mental or emotional conditions. So this would curb any further conversation. The conversation exactly, stops there, then and there. It won't go further. See, instead of that, how we can put up? So I can see that too. See, we are like acknowledging, the doctor is acknowledging what the patient is going through at this point. I can see that too. I can see that you're not feeling good. Tell me what is troubling you. So here we are exploring, the doctor or the nurse, whoever the professional is. If we are like asking like what's troubling you, I can see that you are suffering. So the professional is acknowledging what the patient is going through, and along with that exploring the fears what that the patient might be having. So we are exploring what actually the patient is going through. So we are mostly asking an open-ended question. We are exploring more into the fears of what the patient is having. So always we have to start with, we have to ask open-ended questions, where there is a chance for the patient to open up. So yeah, again, another example. The patient is coming to the doctor and saying, "Doctor, I'm unable to sleep at nights." Again, the doctor is saying that you must be sleeping during the day. This is a first answer, first reply, first response that comes from a doctor. That must be because you must be sleeping during the day. You can take diazepam tabs. You should sleep well. See, here, what the doctor is not doing is that he is not exploring why the patient is having sleeplessness. Is it because of his physical condition? Is it something more? Is it something that has to do with his emotional side, or his stress, or any other fears that the person might be having? We are not discussing any of these points, and immediately what we are doing is that we are blaming the patient. We are blaming, already the patient is in pain, already the patient is in distress, the patient is going through a lot of distress, is not able to sleep. Along with that, we are just adding on the weight by saying that it is you, because of you, that you're not able to sleep. It is because you are sleeping during the day that you're not able to sleep during the night. So we are just adding more blame to the patient, and this kind of what increases what the patient is going through. So instead of that, how we can put up, how else we can ask. I understand it must be frustrating not being able to sleep. Again, we are acknowledging. So the important fact when it comes to a good communication is acknowledging what the patient is going through. I understand it must be frustrating not being able to sleep. What has been troubling you, or what are you thinking when awake? So we are again asking about his fears, what's troubling him. We are just opening a door to much more details into what his condition is. Maybe it's not just physical condition; it might be much more than the physical conditions. So, what is BBN, which is acronym for Breaking Bad News? Breaking bad news is any information which adversely, seriously affects an individual's view of his or her future. Okay, so here, once this information is said either to a patient or the caregiver, their world comes down shattering. Okay, so they completely shatters, they completely break down, they don't know where to go. So it's such an information that we are giving. So BBN, breaking bad news, is that any information, it could be anything, which adversely and seriously affects an individual's view of his or her future. It could be the patient or the caregiver. So I guess you can see a picture over here. Can someone just comprehend this, look through it, go through this, and tell what you feel about this? Anyone from our
First
yes.
one is shape,
First one
not
is
shape, not broken the shape.
okay, not broken in shape. Okay, and second one is kind of broken in shape, right?
Yes.
Oh, okay. So how can we link this to our breaking the bad news? How can we link this to communication? Okay, I can see some of you.
First one, when you're breaking without knowing the thing, and it is randomly you are doing it. So you cannot achieve the purpose. The second one, when you know the trick, when you're breaking it properly, you're not damaging the patient or the caregiver. Nicely, you are developing, giving the message to the patient or the caregiver.
Thank you so much, Ramani Joseph, right? Thank you so much. And I can see a few messages in the chat box as well. One is badly breaking. Thank you, Manjula and Rita, by mistake. It's Rapo. Exactly. So, we can break the same information in two ways. Either we can do it in a way that creates a lot of mess, or we can do it in a proper way. See, the first one is a complete mess. You can see there's a lot of cracks and the mess, the yolk is like all around it. And similarly, breaking a bad news, when we suddenly break a news, we can have this impact on the patient as well as the caregiver or whoever is concerned with the patient. It could have a very damaging effect. At the same time, if we are doing it in a proper channelized, communicating in a proper way, the mess is like much less. The second picture describes that more. That is, the egg is like equally, in a perfect half. Everything is, it's not as such a mess like the first picture. So and maybe in the first picture you can maybe the cracks around it, maybe we can perceive it as the impact the news is having on the people around the patient also. It's vast. The damage that the breaking is causing is vast. Okay, so breaking bad news is similar to breaking an egg. A certain amount of skill is needed, otherwise you are liable to make a mess. So we'll start with a role play. So now this PPT was prepared for doctors. So forget about the general practitioner. You are a nurse. Okay, sorry. So you are a nurse. You have seen a patient about a week back for mouth ulcer, not responded to your treatment. You advised him to go to a surgeon who then did a biopsy. Patient has come to you with the biopsy report which reveals cancer. Now, how are you going to disclose this information to the patient? Anybody, any volunteers?
We can say directly without saying it is a cancer. First, the doctor will tell about the diagnosis. Then we can say nicely it looks like cancer. Further test will confirm. Till then, we can wait.
Okay, so you're saying that you can directly say that it's cancer to the patient.
No, directly it looks like cancer, and further evaluation is required.
Further evaluation is okay. Thank you so much. So see, there are different ways of this is how we shouldn't communicate. Okay, this slide shows how you should not communicate. Okay, I can see a few messages in the chat box. Find out the knowledge, update on the disease. First of all, give a psychological support to the patient. Thank you, Jyoti. Right. So yeah, this slide basically shows how you shouldn't be communicating. For example, your report says that you have cancer, get admitted. Let's see what we can do further. See, immediately the patient had a very okay kind of life. You know, the patient did not think that the patient is going to have cancer today. You know, the patient was living a normal life, and today the patient is going. You know, if the patient is having a job, a family, everything is there. Everything was going on in a proper way. No other issues were there. And one fine morning, he did this biopsy and goes to a doctor, and you know, the doctor says that okay, you are having cancer, and this completely shatters the patient, you know, because he's not prepared for this. Again, another thing, another way of communicating, another way of not communicating. I'm sorry, you have been diagnosed with cancer. Perhaps it's already been advanced, and I guess we don't have much treatment. Maybe you might have another 3 months to live. Again, the patient is upset, the patient becomes lonely, and at most cases there is a chance that the patient might do something, you know, some commit suicide, you know, go to an extent where, you know, he takes his life. Or the caregiver, you know, the caregiver may not be able to digest or comprehend this news. So there is this way of communicating, and we'll come how to communicate. Okay, how the communication has to be done, we'll be dealing with that in later slides. Why do you think this is difficult? Communicating bad news or breaking the bad news is difficult. First of all, environmental barriers. For example, see, when we are working in a hospital setting, we do know that, you know, it's busy. We are having like a lot of work going around, and we may not have that much privacy or space where we can sit with the patient and, you know, explain or inform that so and so is there, so and so is there. So one of the major barrier is environmental barriers. We don't have proper space, privacy, external interference like phone calls, emergency crowd noise, or media. Next, why is it difficult for the families to ask to gain more information from the doctors? They feel that the doctor is too busy and do not know how to ask. So the patients from their part, they feel that, you know, I shouldn't probe much into this information. Maybe I shouldn't, the doctor may not be interested in my emotional side. I shouldn't say my fears to the doctors or nurses. I shouldn't say much to them. Maybe they don't have time for it. Maybe they are not interested in my emotional side, or maybe they are only interested in my physical side. What if the doctor says something which I might not be able to accept? What if I break down in front of everyone? What if I break down in front of doctor or nurse? What if I demand more clarification? What if they stop treating me? So there are a lot of fears and concerns that's there with the patients. Okay, that's why the news won't be, the patients might have some barriers of asking questions or gaining more information. So from the patient side, they feel that the doctor is too busy, or the professional, whoever it is. It could be a doctor, it could be a psychologist, it could be a social worker, it could be a nurse, it could be any professional. Okay, they feel that the professional is too busy or do not know how to ask. They fear the answer. What if they say that I'm having cancer? I don't want to know that I'm having cancer. I don't want to I don't want to hear that. So I won't ask. I won't ask what the report says, or I don't want to probe much into it. What if the doctor is more interested in the physical care and do not want to care of their emotional problems? Frightened of breaking down in front of us, in front of the professionals. If they demand, what if the patients demand more clarification? What if the doctors stop treating them? So these are the fears that comes from the patient side or the family side. And why is it difficult for the professionals? Why is it difficult for us? Why is it difficult for the doctors, nurses, social officers, psychologists? Why is it difficult for us to break the news? Because we fear of getting blamed. Most of the time, it is seen that when we go and reveal, or when we go and say the news, and most of the time we have seen that they put the blame, this is because of you, because you have not treated well, this is because of this hospital, there is a chance of putting the blame on us. So fear of getting blamed, letting the patient down, most of the time we don't want them to feel bad, we don't want them to feel, we don't want to let them down. So these are the concerns that comes to the professionals. What if the patient asks difficult questions? What if the patient's family starts crying? How will I manage that? How will I manage the whole scenario or the whole situation? What if they get angry? Wanting to protect the patients. How do I reveal a bad diagnosis to the patients? Like, I want to protect the patient. I don't want the patient to know that, okay, he is nearing the end. I don't want him to know. So, we are like trying to protect the patient, to protect the patient's emotions. Not enough time. Most of the time we are not having enough time to sit and talk or reveal the information. Being a reminder of human vulnerability, the family does not want me to know. So most of the time what happens is that the doctors or the professionals assume that the patient or the family does not want to reveal the news. So we kind of keep the information back, we hold the information back. So what happens with the professionals is that they fear of getting blamed, they fear of letting down the patient. They want to protect the patient, the emotions. Most of the time, they may not have enough time, and they feel powerless, awkward, etc. And what do you do when we have this? We don't want to communicate. We knowingly or unknowingly take up certain distancing technique. For example, if she is the patient, okay, she is beside me, I won't give eye contact. What I will do is I'll immediately take the notes or whatever is in my hand. I won't face the patient. I'll just, okay, so what's going on? I won't give eye contact. I won't properly communicate. I'll pretend that I'm busy. I'll manage something else while having a conversation. So poor eye contact, always busy, facial expression, tone of voice, concentrating on physical tasks. So I'll be taking my phone, I'll be taking other notes, I'll be prescribing medicine. So I can't face the patient. I don't want to reveal the information. I don't want to share the information. So I'll do whatever is possible for to distance myself from the patient or distance myself from breaking the bad news. Categorizing and labeling, like, she's a difficult patient. I don't think I can, manage the medical side. Never inquiring beyond physical symptoms. The doctor distances or keeps it's not necessary, it has to be a doctor, the nurse or the doctor, whoever is, we don't probe much into the emotional side, because what if I probe into the emotional side, and what if the patient actually opens up? Will I be able to manage? So I'll keep distancing. I'll just look around the physical sides. Okay, is there pain, or I'll be asking more about the physical conditions. So distancing technique is one thing that we often see being taken up by doctors and nurses in institutions. So we'll avoid, it's like avoiding that conversation from actually happening. And another thing is we often use leading questions. For example, we in our questions itself, we give answers. Your pain is better, right? You're much better, right? So we'll make the patient in an awkward position where the patient won't be able to say a no. Mostly like a directed question. The answer is, it's called leading questions. It's directing questions, and like the answer is always there. We put the patient or the family member in a position where they won't be able to deny. They won't say no. Okay, your pain is better, right? So the patient might think, oh, okay, the pain should have been better or maybe better. Even if the patient is having much pain, the pain has increased or having much higher pain, the patient might say, yeah, I think I'm feeling a bit better. So premature assurance, don't worry, I will handle. We are giving false hope. Don't worry about a thing. I'm here, right? I'll handle it. We can manage this. This might be this is okay. We think I can handle this. We are giving false hope, and speaking too little or too much. And often we avoid conversation, or we have a lot. We talk too much, inappropriate humor, and we have a very. I have not seen it very often, but there are people who use humor to make the moment lighter. but it has a bad effects in its own way. So I'll just pause. Am I okay till here? Are you able to follow me?
Yes.
Thank you so much. Anyone else? Can I have responses from more people? Thank you. Thank you, Rita. Thank you, Manjula. So yeah, in order to avoid conversation, we use distancing techniques. So importance of learning to break the bad news. It's for to maintain trust between the physician. It's to maintain trust between the doctor, nurses, whoever is the practitioner, and the patient. To prevent inappropriate hope and guilt. To avoid giving false hope. To allow appropriate adjustment. What if the patient has to make certain adjustment according to the conditions, according to what level she or he has reached? So in order to make appropriate changes or adjustment, to prevent a conspiracy of silence. Again, we have already discussed the conspiracy of silence, where both the parties know what they are going through, but they are not ready to discuss this, or they are not ready to come out openly about this. They are not ready to share this amongst themselves. So to prevent conspiracy of silence, where they suffer alone, they both know what they are going through and they suffer alone. So in order to avoid, or in order to prevent that, so to maintain trust, to prevent inappropriate, or to prevent giving false hope, to allow appropriate adjustment, and to prevent a conspiracy of silence. So basically, this is how we are like about to start how to break the bad news. Okay. So there are 6 steps to breaking bad news. First one, we'll look much deeper into each point. Getting started, find out how much patient knows, find out how much the patient wants to know, sharing the information, responsibility to the patient's feeling, planning, and follow through. So these are the 6 steps where which we take in when we are about to break the bad news. So getting started. So you cannot just randomly go to a patient and just start the conversation. You have to be planned. You need to ask appropriate questions. So you need to have an idea of what you are going to ask. So plan what you will say. Ask appropriate questions. So you have a basic idea of what you are about to ask. Create a conducive environment. Allow adequate time. It's not that you can just go and talk and come back. This is going to take some time. So make sure that you are having adequate time for having this conversation. Determine whom to involve, whether it's any other family member you want to involve, whether you want to involve any other a professional from your side. For example, from our side, when we break the bad news, mostly there could be a doctor, there could be a nurse, or there could be a doctor and a psychologist, there could be a doctor, psychologist, and a social worker. So we need to think whom all we are going to involve when we are doing this. We are going to break the news. So plan, just don't randomly go and break the news. Have an idea of what you are going through, how we are going to present this. So obviously we'll start with the rapport. We'll comfort him. We'll make sure that we are having time. We'll sit beside the patient, and we'll establish what the patient already knows, what he or she is having an idea, to what extent he or she knows the disease, about the diagnosis, about the prognosis, about the stage that she has reached, about whether she is deteriorating or whether she is much better. So we need to know how much the patient already knows before we give any other information, any much information. So we need to get an clarity of how much the patient knows. So ask question like, what do you think? What is your condition? If at all the patient is not knowing the condition, so ask what do you think? Why do you think you are here? What is your condition? And what do you think? To what extent it has reached? So we'll get an idea of how much the patient knows. Assess ability to comprehend new bad news. So we have to assess whether the patient is able to take more information from us, whether the patient is ready or willing to take the bad news more. So first of all, we need to plan on what we are saying or what we are communicating. Secondly, we need to assess, we need to know what the patient already knows about his diagnosis, prognosis, and all. Only then we'll go about the third step, that is how much the patient wants to know. So consider a situation where when we do it, so we'll ask what do you know. So obviously the second step is how much the patient knows. Secondly, we'll be asking the patient whether he or she wants to know more about his condition. Do you think, do you want to know more about your conditions? Do you think much more information do you need to know much more about your condition? So we'll be taking the consent of the patient whether he or she wants to know more about his or her condition. So recognize, support various patient preference. So if the patient is saying that, the patient does not want to know much about this, we cannot force the news into the patient. Okay. And if the patient is saying that, I would like to know more, if at all he is saying that he is willing, if we have the consent, we'll be giving the information, the whatever it has to be taken. People handle information differently. So we need to, throughout the conversation, we need to look at his emotions, his affect, his physiological side, his physical side, so that, we know that he is okay, he's ready to take the information. So at this point, it's called invite. There is a spike protocol which will be coming later. So at this point, we'll be asking the patient, we'll be taking the consent of the patient whether the patient wants to know more about his condition. And the fourth step is actually where the information is shared. So sharing the information, save, then stop. So we need to have adequate pause in between when we are like breaking down the information. And at each pause, we need to assess how much the patient has comprehended, his emotional side, his affect, everything, whether he is, he's okay, he's ready to, accept the information and all. So check what the patient has understood. Is it possible to explore more concerns while giving information? Pay attention to emotion, which is very important. Painful concerns may remain invisible. They need to be propped. Be clear, gentle, and slow. You cannot just suddenly break the news to him. You have to break it in a very in a gradual way and give adequate pauses. And in between each pause, you need to assess the patient's emotions and other concerns, the physical side, the effect, how the physiology is changing, everything. Okay. So don't minimize severity. Whatever you are saying, you have to say the fact. You're not decreasing the severity, or you're not saying what you're not giving any false hope. You have to give actual fact as it is, but in a very gentle, clear, and slow way. And responding to feelings. Obviously, once we give the information, the patient might show affective responses. It's the emotional responses that the patient is showing. We need to respond to it, like whether if we need to give some time for the patient to comprehend, we need to do that. We need to, if the patient needs a point where, the patient is breaking down, give time for that. It's not that you can cut short breaking the bad news. I know you can just cut short and come back. No, you have to give space where the patient can emotionally vent out. Cognitive responses, we need to know whether the patient has understood, comprehended what we have given, or if the comprehension is in par with what we think. And if at all he is having more concerns or he needs more clarity, we need to assess that also. Basic psychophysiological response, obviously, if the patient is stressed or if the patient is showing any other physiological responses, like in any other difficulties, stressors, or anything like that, we need to assess that. Give time to react, which is very important. The way patients might react, we cannot never perceive how each patient might be reacting in a different way. So give time for that. Sometimes they may not need time, but for patients who might need time to react, please give space, whether it's crying or it could be anything. It could be any emotional ventilation, any kind of emotional vent out, but give space for that. Listen. And obviously our non-verbal communication plays a very big, huge role here, which I think you might have taken in your previous session. It also takes a lot of importance here. And the last is planning and follow-up. Plan for the next step. Sit with the patient and discuss the potential sources of support. What can be done, who are there to support you, what are the next level of treatment. Give contact information, if at all you have any references or whom to contact, any other way of support and all. So that's how we end the conversation or the communication. So we'll just go through once again. So getting started, we plan before we need to have clarity on what we are going to speak, and we'll explore how much the patient is knows already, and we'll take consent from the patient. How much the patient wants to know, whether he wants to know, and sharing the information obviously in a gentle way, and responding to the feelings. It could be his emotional side, the thoughts, anything, cognitive side and all, and then planning and follow up. So that's how we break the news. It's usually we follow Spike's protocol. That is, S is for setting up, where we make the space ready, where there is privacy, where there is everybody in a comfortable space, and we'll decide whom to get involved and all. Perception is where how much the patient is having the perception of his disease, his diagnosis, prognosis, and how much he knows, how much idea he has about the disease. Invitation is actually inviting the patient, whether he wants to know, whether the patient wants to know much about his condition. And knowledge, that is where we share the information. Emotions will as such the emotions come, we need to give time for him or her to express the emotion. And strategy, that is where we close this communication, we close a conversation, and further plan follow up is done. So that is the Spikes protocol that we usually follow, and this has been already discussed in the 6 steps, which was done previously. So I'll just discuss a case where we actually had to do this. So there was this case of a 23-year-old woman. She was suffering from osteosarcoma, right pelvis, pelvectomy was done, but now she was having pain in her left leg. So we have regional cancer center. It was informed from RCC that the cancer has spread through the left leg also. Okay, and this information, the parents knew this information, but the parents was not ready to convey this information towards the patient, okay, towards the 23-year-old female. So we had to sit and talk with the parents in the beginning. We had to get their concern first, so that finally we can break the information to the patient. So in the first admission, the parents, they were not at all willing to break this information to her. They completely denied. They were saying that, why do we need to do this? She's okay. If at all she comes to know about this, she'll be more sad. I am not willing. Especially the father was not willing to share the information with the patient. But we said why this is important, which will be like the collusion part we'll be discussing in the next session. Why this is important, why we need to break the news and all. So finally, we took the consent from the father, and they said that they are not ready to break the news, and we have to do. Okay, so the team had doctor was there, nurse was there, psychologist was there. So we sat with the patient, and before this happened, the patient was showing a lot of aggression, aggression towards the mother. A lot of tantrums was being shown by the patient. So actually, she's in the last stage. Okay, her condition is deteriorating. It has almost spread, and she's not able to sit. It has spread throughout the hip, and also she's not able to sit. So she knows, and her left leg started paining. Okay, and the parents kept assuring her that you are going to be okay. We'll take these medicines, and once these medicines are, we'll go back to RCC and get the surgery done, and then you will be fine. But she was having this feeling that why is my left leg paining, and why I don't know why they are saying that nothing is wrong with me, but still I know that my left leg is paining and I'm not able to sit like before. And also she was having this conflict within her, and also she was throwing tantrums towards her mother. So once after the consent from the mother, we sat with her, and we probed into how much she knows about her condition. What so her comprehension was that once from here the pain is reduced, she'll go back to regional cancer center and she'll get the surgery, or she'll again start chemotherapy and all, and she'll be in a much better position. At least she'll be able to sit in a wheelchair. That was his idea. So then we asked her, like, do you want to know more, to more? Like, that's inviting, we are asking her, we are taking her consent, we are inviting her. And she said she would like to know more. And then finally, the doctor, actually the medical side, the physiological, the physical side, and all, the doctor kind of explained, and how it has spread to the left, and how I'm just saying in a very hurry way, but this is not how we do it in the actual setting. We take a lot of time. We take like an hour or 2 hour, like 1.5 hours for this session alone. So we sat with her and gave the information, and she was crying and all. Actually, after this, after we broke the news, she didn't talk to her parents for 3 days. And she used to talk with only one doctor and the psychologist. Okay, she used to talk to only two people. And what she said in my session was that, why did they keep this information from me? I have been asking this from the very beginning. I know that something bad is happening to me, but why didn't they say? They just gave they always gave me assurance that everything is going to be all right. Why did they do that? And she did not talk completely to the parents for like 3 days, but her aggression kind of came down. The conflict that she had within came down. And after 3 days, she did start talking. And the tantrums, the aggression towards mother, everything kind of decreased. So she was in a much, she felt better after the breaking the barriers. I would say that, other emotional, the stressors factors side came down. So that's how we usually do it. We need a lot of time when we are doing this session. Anything you would like to discuss, or any questions or anything at this point? Okay, shall we move forward? Anything would like to add? Anything? Anybody would like to add anything? Any thoughts on this? On how to break the bad news? Any doubts? Any queries? Anything?
Hello.
Yes.
Hello, ma'am. Good evening.
Good evening.
Ma'am, before breaking the that news, first
Yes.
take the client consent. Then allow if any relatives they need to listen his diagnosis. Then allow the patient relatives by the consent of patient. Then before breaking this news, then with the gentle, with warm, give the autonomous to the client. So by her consent, her autonomous, but surrounding environment, if they need the relatives or patients or any other health personals, sometimes they don't want to reveal with even second person also. Doctor is the first person, then second person. So at that time, before we need to take the consent autonomous to the from the client.
Obviously, we need to get the consent from the client, and more than that, we are more focusing on about the patient, his willingness to open up, because the patient, it's not necessary that the patient might be in a position where he or she is ready to give this information to everybody. He or she might have her own concerns and fears and all. So we might need to sit with the patient, take the patient's consent. Did I make it clear?
Yes, ma'am. Yes, ma'am.
Thank you. Obviously, we do take consent from the immediate caregivers. For example, if the parents are there, obviously we take consent from the parents, because that's exclusively that's done in India. I think it's not widely done like that in Western countries, and it's directly the patient we approach to. But in India, we do take into consideration the caregivers' consent also. So we do take consent from the caregivers, and then only we'll be like taking the patient consent is as important as the caregiver's consent. Sometimes there are possibilities that the caregiver is not ready, but if we ask the patient whether he or she wants to know more about the condition, there are chances that we have seen cases where they are willing to know more. So in those cases, we do tell directly to the patient. Okay. Thank you, ma'am. So we'll be moving on to pollution. So collusion is actually withholding information. Okay, information about diagnosis, recurrence, prognosis in the advanced terminal stage of a disease, and medical details about the deceased person withheld from the significant. For example, the caregiver is not willing to say that the condition is poor or the prognosis is bad to the patient, or the patient or the where the family members is not ready to say this information to other members. It could happen in any way. Anyway, collusion is withholding information which might have an adverse effect for the information about, especially about diagnosis, about bad prognosis, the bad prognosis, the recurrence, everything. We withheld this information. We don't give this information to the patient. So collusion is an act of love. We often feel that why do we need to break this information to her? Anyway, she is happy. So why do we need to break this information and make her sad? So that is what is called as collusion. So collusion can occur between professional and relatives. For example, the doctors or the nurses might feel that the relatives do not need to know this information. Why do we need to break them down and all? Sometimes happens between the relatives and the patient. For example, the caregivers, like the previous cases, whether the parents know the conditions was prognosis was bad and the condition was deteriorating, but the parents was not ready to break the collusion to the patient, to the doctor. So it can happen between relatives and patient. It can happen between relatives and relatives. So it can happen between the family members also. So why do we do this? What are the basic reasons for collusions? Done with all good intention and good faith, because we don't want our loved one, we don't want our close people to get hurt. We don't want them to go through a bad time. We don't want to hurt them by saying that, your condition is deteriorating. Fear that the patient might give up. What if the patient is not in a position to accept this news? And what if the patient goes into depression? What if the patient commits suicide or commits an act where, a dangerous act or something like that? What if the patient hurts himself? So fear that the patient may give up and die if told the truth. Belief that the patient may not be able to cope with the truth about poor prognosis. So these are basically the assumptions that the people who withheld this information is having. Okay, so this collusion is done with good intention. Obviously, we don't want them to suffer. We are like protecting the people we love. That's why we are keep withholding this information. What are other reasons for collusion? Property issues and disputes between relatives, concerns about causing trauma to relatives. For example, sometimes the information is withheld from the father. The mother might be knowing that the mother is not ready to say this information to the father about the daughter's condition. So in any way it can happen. So what if the father is not able to accept the fact? What if the father collapses completely once he knows this information? So these are the reasons why we keep withheld this information. Social stigma. What if others come to know that my daughter is having cancer? What happens? What will they think about us? This social stigma is there. What will happen about her future? So see these kind of stigmas also are the reasons where collusion is there. Ignorance and lack of awareness. So effects of collusion. What happens when this information is actually withheld? Honest communication is hampered. So there is no free, or there is this big gap between the people or whoever is withholding the information. Elevated emotional and psychological distress. Obviously, like in the previous cases where the patient already knew that something bad was happening to her, but she was not having clarity to it, and this caused an internal conflict in her, which kind of came out as aggression towards her mother. So these kind of internal, emotional, and psychological distresses come often. Loss of precious time, isolation, anger, guilt, frustration, loss of trust, and there might be a lot of unfinished business that the patient might be having, which we may not be aware of. And if we break the collusion only, the patient might come out of, see, I have so and so wish, I have so and so desires, I like to do this, I like to do that. So there might be a lot of unfinished business that the patient might be having. So if we withhold the information, okay, the condition is deteriorating, the condition is deteriorating, you might, end soon. The information, if we withheld, what if, who is going to do all these business? How are we ever going to come to know about the desires, the wishes and all? So there might be a lot of unfinished businesses. So honest communication is hampered. Emotional and psychological distress is there. Loss of precious time, isolation, and we have this anger, guilt, frustration, as I mentioned earlier, and a lot of unfinished business might be there. Both parties are grieving but alone. Again, conspiracy of silence. Both of them know that the condition is deteriorating, something bad is happening, but this communication is not coming out openly, and they both are suffering. They both are they both are sad. They both are depressed. They both know that the something is happening, but they're not coming. If at all we do break the collusion, we break the bad news, and we have somebody to share this news, and that is a big relief. Even if at all the condition is deteriorating and we are grieving together is different than grieving alone. That is a big thing. If we have one or two people to grieve with us, we feel the weight is much less. But if we are grieving alone, the caregiver, the mother is also grieving, the child is also grieving, and they both are alone. They both are not expressing what they are going through, and that is another conspiracy of silence is another effect. Constant stress and burden of hiding the truth. So most of the time, if it's a spouse, the spouse is always taking this. If it's a wife, the wife knows that the condition is deteriorating. She's not able to say this openly to the husband, and she's carrying this baggage. And the stress that the wife, she's not able to sleep properly. She's grieving alone. She is depressed. She's not as her appetite is not proper. So everything kind of comes down because she's withholding the information. So this burden, this baggage she's been carrying. Inability to eat, sleep, and communicating with others, patients feel out of control and trapped. The same with the patients also. They also feel, they're out of control, they have been trapped, they have, the information is being hidden from them, and they feel cheated upon. Actually, that's the one thing that the patient asked me, why did they say, why did they lie to me? Why did they have to do this to me? So they feel cheated upon. So this is again a case. Amrita, 65 years old female, has been diagnosed with CA ovary. Sanjay is her son and he has come to meet you. He appears confused and restless. He do not want to reveal the diagnosis to his mother. How will you handle Sanjay? So how are you going to handle Sanjay? He does not want to reveal the information to his mother. He does not want to say to his mother that she is having CA ovary. So such a person is coming to you. So how are you going to deal with this person? Anyone would like to give it a shot? Give it a try? You can put in the chat box as well, okay? How are you going to manage?
It is the same case like there's osteosarcoma. The mother did not want to share the thing to the daughter. Same situation.
It's not proper, Ramani. Can you just please elaborate on that, or can you please put in the chat? You're actually talking to the son, okay? The son does not want to break the news to the mother. So how are you going to handle? How are you going to convince him? Would you like to
Hello.
continue? Yes, please.
Ma'am, good evening, ma'am.
Good evening.
Ma'am, first we have to motivate to his son. What are the if we are not exposing this incident to the mother, then what are the advantages and the disadvantages if we are prolonging without giving the information to his mother? After that, what are the mother will get the problems? Maybe it might be third stage or fourth stage. After that, what are the problems will come? Even death also she will go. So this all things, the son first he knows very well. We have to give the awareness regarding this all stages to his son. We have to give them more information to the son. Then we have to give the advices with a gentle manner to reveal these incidents to his mother. We will give the advice to his son. Otherwise, we will give you get your mother. We will reveal this matter with a gentle manner. Like that, we have to give the advice to the son.
Thank you. Thank you so much, ma'am. Exactly. And thank you. Someone has mentioned the chat box also, counseling, psychological support. Thank you. So exactly, we need to explore what his fears are, like what is it like stopping him from actually breaking the collusion. So acknowledge collusion, acknowledge the fact that okay, there is this collusion. He is withholding the information. Explore the reason why doesn't he want to share this information with his mother? What is stopping him? What are his fears? What is he scared of? With the relatives concerned, elicit worries and questions regarding illness. Feedback to the relatives regarding awareness of the illness. We need to sit with the caregiver. If it's in this case the son, we need to sit with the son, give him as much information in our as much as possible, the information regarding the medical condition, mother's condition, what are the possible ways, how it is going to be, the prognosis, diagnosis, everything. We explain the relative the importance of reassurance and honesty, and why this is important, why breaking this information, what the importance of unfinished business. There might be something else that she might not want to do. So we like ma'am said, we give more awareness into the importance. Encourage dialogue between the patient and the relative. So we try to encourage the dialogue we encourage this conversation between the caregiver and the patient. And if at all the caregiver is not willing to break, only we ourselves will be involving in the breaking of collusion. Value statements by family members, obviously, if they are thoroughly saying, especially in an Indian scenario, Indian situation, if they are thoroughly saying not to say, we might need to respect that also. Again, if we ask the patient and if they are, if we invite the patient and they are willing to know more, we can obviously say. But there might be certain point we have to like each cases is like different. So we need to approach as per the needs. Acknowledge family members' emotions, listen to family members, understand who the patient is as a person as well as who takes the decision, elicit questions from family members. And finally, we need to ask ourselves, did I listen? Did I explore their beliefs? Did I explore their fears? Did I make acceptable working diagnosis? Did I share options for investigation? This is like for self-reflection. Okay, did I share in decision making? Did I make some attempt to see that my patient understood or comprehended what I wanted to? Did I develop a good relationship, which is like most important? So what are some of the take home messages? Best learned through experience. Breaking the collusion or communication, this does not happen, in a day or two. You cannot just by heart this whole PPT and do the communication. This comes with practice, this comes with practice. It's a skill that we have to develop. It won't come naturally to us. Some people might be blessed with it, but most of the time we need to develop the skill. So for developing the skill, we need to have an idea of how to go about the communication, how to break the bad news, how to see if the collusion is there or not, how to break the collusion and all. And we need to practice, we need to absorb all the information, and we need to put this into practice and gradually develop the skill. So it's not something that we can do suddenly, and with each session we will be in a better position to break the bad news or in a better position to communicate. So there are no fixed guidelines or anything. There is no like you have to do this, that, and all in a proper way. We just need to have a structure. We just have a basic structure how to go about it. So it should be patient centered always, and context and culture oriented. Accept the limits. There we have our own limits. We need to accept that also. There is no role model. Never assume what the patient knows, what the caregiver knows, or what the patient wants to know, what the caregiver is thinking. So never assume. Have an open communication. Do proper communication and have an idea of the comprehension, perception, and all. So with that, we actually come to the end of the slide. Anyone would like to have a discussion on what we discussed, or any other or any other doubts, queries, or anything?
Thank you, Rajika, for the wonderful presentation. Anybody wants to ask anything or share your experience also, you can.
Where you had to actually face this, the breaking the bad news, or where you had a very bad outcome, or where you facilitated it.
So from today's class, what we need to understand is nobody wants to hear a bad news, right? So if you want to hear the bad news, like a cancer, if you do it in a correct way, the step by step, so they will be able to digest. So that all things you have to keep it in mind always. And always remember the spikes protocol. If someone wants to listen their bad things, so we need a good setup. That is spikes first thesis setup, because during the breaking bad news time, they will express some emotions. We need to manage that. We need to overcome that situation. So we need a proper that knowledge how to handle that situation. And P is perception. Before breaking the bad news, we need to find out the ideas, their mind. So how they are understanding about their illness, and based on that only you have to that break the bad news. And sometimes they can okay, they will say like, okay, I have cancer, I know I have cancer, but they don't know how what is cancer. Okay, so that all things you have to that keep it in mind all before you invite the patients. First is setting up, the second one is perception, and the third one is I is invitation. So you have to invite the patient along with the caregivers. And the next thing is, I already said, while communicating, so they will express emotions, and also we need a good knowledge to communicate, how to communicate. That all things you should know before communicating bad news. And if they express some emotions, like they will cry, sometimes they will angry, sometimes they will anxious, so we need to overcome that situation. After that you have to give a proper strategy plan, or you have to give some summary, because we are here to take care of your problems. That is the positive message you have to. I know you have an incurable cancer, but we are here to support you. We will be able to relieve your symptoms as much as we can. That is the positive things you have to give to them, and then you can conclude the conversation. Okay. And the next important things, Madam was shared the collusion. That also important thing, because nobody wants to that allow their loved ones uh, cry or anything, that kind of thing. So nobody's with. So that's why they will be trying to hiding the truth from their loved ones. Because if they knows the truth, they will be sad, no? So that is why they will be always they will hide the truth. But we know that diagnosis should know the patient, his his or her right, but without permission from without taking permission from the caregivers. If there is a collusion there, you have to take permission from the caregivers, convince them well, because this is very, very important. They need to cover some unfinished business. If they knows the diagnosis, they can able to do like that, that kind of things. So that make them understand well, and then they will agree. But after that, you have to give one more thing. We don't how to give it, how are you going to break the bad news there? That all things, if they agree, definitely sometimes the caregiver will say like, okay, uh, you can uh, share the patient with the bad things, you can share with their loved ones, but inside their mind always, because how are they going to say, like, cancer, do you have, like, you know, you are having cancer, that kind of immediate this. So we don't like that. So we know how to communicating bad news. So we need to convince the caregivers first, and then you have to convey how are you going to break the bad news also. Then only they will understand well. Then they will be happy and they will be able to sit along with the patient. So that all things you have to keep it in mind all the times. Anything you want to add?
No, ma'am. I think there's a query in the chat. My question is,
In
patient.
6 steps support various patient preference. Can you explain? Remini ma'am,
Yes, madam. In the 6 steps you had explained, in that second steps, how much patient wants to know. Accordingly, we have to explain. In that one point, support various patient preference. So, can you tell about that?
wait a minute. We are going to share the PPT again and come to that.
Hi, Manjula. I think there's a question in the chat box, but can you please elaborate on it? Can you be more specific? It's not clear. You can use the chat box if you're not able to unmute. Can you make the question a bit more elaborate?
In this third point,
Right. The thing is, we need to know what the patient wants, what the patient's preference is, whether, the patient wants to know more about the disease, whether the patient wants to know more about the prognosis, diagnosis, and also we need to know the patient's preferences. And we need to support that. We cannot push the information into the patient. We cannot force the information onto them.
Yeah, yes. So before breaking the bad news, we should know actually the patient wants to know.
Whether the patient wants to know.
So if the patient wants to know the diagnosis, then we can able to break the bad news. Otherwise, we will stop it there. So we will give more information, but till that the patient request, we will break.
Okay, thank you, madam. That means if the patient don't want to know more about that, then we should not push.
Exactly.
No,
Exactly.
Yes.
Okay, thank you, madam.
Thank you. Hello, Manjula ma'am. I think you are saying about the collusion part, right? If at all the caregiver is willing to break this information to the patient, obviously the next step is we'll be taking the next consent. Obviously, we'll be asking the patient's consent again. Even though the caregivers has said that we can break the news, break the collusion and all, even though the caregiver has given us consent, again we will be obviously asking the patient's consent. Do you want to know? Again, the same protocol will be following.
You can say something like serious things. If still, would you like to know? So that kind of things, because the caregiver, the patient doesn't know the diagnosis. No, they will because they before they will be sharing some kind of ulcer in the stomach, but the patient is also having already having CS stomach with the multiple metastasis. So that time the patient may thinking like, okay, I have a cancer, I have a ulcer, no. So that is why the doctor referred to me here for relieving my pain. So that is the insight of the patient. But the caregivers knows everything. So sometimes the collusion will be there. Once once we are able to convey the things. So sometimes the caregivers agree. Okay, you can share. So, but after that also, as ma'am said, you have to ask the patient something like a serious condition. Still, you would like
Would
to
you
know.
like to know?
Yeah, would you like to know? So then they okay, and though some kind of serious illness is there, so then they have a mind settings. No, they will prepare their mind for hearing the bad things. Move on to the case presentation. Miss Lily, ma'am.
Ma'am, I will just add a
Yes.
note to it. Actually it's called warning shot. Okay, we are actually saying that the it's not a very good thing that you are going to hear. It's something serious, and still would you like to know? It's a warning shot. We are actually already conveying that the news is going to be bad. It's called as a warning shot. Okay, as we'll proceed to the presentation.
Okay, yes.
Good afternoon.
Your voice is not clear. Lot of background noise.
Good afternoon, ma'am.
Yeah, yes. Good afternoon.
Yeah. My name is Lily D'Souza. Today I will present the case on CA vagina. My patient's details is Mrs. Hira Raju Charnia, female, age 62 years, diagnosis squamous cell carcinoma vagina, carcinoma wall sac. Patient was presenting complaints was fever with chill and complaining of PV discharge with bleeding. And patient came with complaining of lower abdominal pain, constipation, and loss of appetite. History of illness: history of abdominal pain with PV discharge last 1 year, and bleeding per vagina for 1 month was there. Abdominal distension and constipation, disturbed sleep pattern, decreased oral intake, admitted for the same complaint, and after CT scan it was diagnosed as squamous cell carcinoma wall sac. After 1 week, patient was discharged after giving antibiotics and was better. On examination, it was ECOG 2. Patient was conscious and oriented. Temperature was 100. Pulse 118 per minute. Respiratory rate 22. BP was 120 by 80 mm of Hg. X-ray chest was no significant abnormalities. Vaginal swab was positive for Gram bucci. Urine routine was negative. Urine culture showed mixed morphotypes growth. Breast tenderness was present, and per abdomen was soft, non-palpable mass, no free fluid. PV examination was hard, irregular, walled grown extended to lower vagina on left side, just above the introitus, bleeds on touch. Important false mass, CA vagina was there. Treatment and significant investigation. CA 19.9 was done. CA 125. All routine blood test was done. Triple H was done. X-ray chest, IHC 2%. Wall biopsy. PET CT scan shows heterogeneous mass involved. Palliative and BSc service and palliative radiation with high risk concern. Antibiotics and symptomatic treatment was started. Psychosocial aspects was she is worried, anxious, and depressed about the disease condition. Financial tension about treatment because his son only was working. Legal issue, family matters cases were there. Collusion because the son doesn't want to tell this to the mother. Spiritual issues, granddaughter's marriage. Medication, she was on discharge, TAP Calpol 650 TDS, TAP Tapal 50 mg SS for severe pain, TAP PAN 40 mg OD, syrup Primafin 3 TSF HS for constipation, TAP 10 mg half TDS, and TAP Imset 4 mg TDS for vomiting. Main concern was pain, financial problems, anxiety related to disease, and collision. Summary, 62 years old with CA vagina with severe pain in lower abdomen, pain with PV discharge, weakness, and abdominal discomfort. Discussion point, symptomatic care for this patient. What are the problems faced by the patient and what all can be done for this patient? Thank you.
Okay, thank you, ma'am, for the presentation. I think this presentation is clear to everyone. Today our topic is on communication and especially communicating bad news and collusion. So I know this whole point is very, very important. We need to discuss, but we are going to discuss about collusion today. And most probably upcoming weeks, we will discuss the same patient again. Anyway, we will go on the collusion part. And we would like to hear from you all. If you have seen this kind of patients in your settings, how will you manage? Your suggestions. We need to help Sister Lily. So please give your suggestions. You can unmute yourself and talk or put your answers in the chat box. Here we came to know that there is this collusion is positive. So we can say that collusion is positive or negative. Okay, positive when there is this collusion, the information is withheld. So here the collusion is positive. So I think the caregiver is daughter, right? Sister Lily, who was a caregiver?
Son was there. Son was the caregiver.
So the son is not willing to disclose the information to his mother, right?
Mother, yes.
Thank you, Sister Lily. So the son is not willing to disclose the information to the mother. So the collusion is positive. So how are we going to tackle this? Anyone would like to volunteer, or shall I call names? I can see a few faces. Rohitash Kumar, right? So any new speakers, Pooja, I can see a few faces, Ashante. So would you like to share how we are going to, take this case forward?
Again, I think as Narak Remini has said, and also in the later case discussion also, it was already discussed that, we'll sit with the caregiver, we'll talk to him, we'll give awareness of why this is important, what are its advantages, why this we need to do this collusion thing, why we need to break the collusion, and we will sit with the caregiver, and that is again going to take another session, okay, to convince the caregiver. So we'll convince the caregiver, and once the caregiver gives us the consent, again we'll be like talking to the patient. Again, we are going to take the consent from the caregiver, not consent as such. Do you want to? We'll sit with the patient and we'll give the warning shot. The news that the report is not that very favorable. Do you still want to know? Do you want to know much information about your condition? Again, that's a warning shot. And once the warning shot is given, the patient has to give her or his consent to give further information. And then the medical side, whoever is it, most probably the doctors will be like giving the physical medical side, or the nurses will be disclosing the medical physical sides and all. And we'll be breaking the news very gradually. And that is going to take another session, with the patient. This is just like a 2 different session that is going to take. Anybody would like to add to this? Any other thoughts on this case? I know that there are certain points that we need to discuss. These points will be discussed in the later sessions, okay? Because we dealt with communication part and breaking the bad news and all. So we are just focusing on the psychosocial side. And the other side, like the symptomatic management and all, we will be discussing in the later sessions. It's not something that we are not taking. We are not doing this today, okay? We will be taking into consideration in the coming sessions. As our time is, we are almost going to wind up. Anybody else has any queries, doubts, or you would like to add to this case presentation? Any thoughts?
So one more thing, pollution. So the son wants to hide the truth from his mother, right? So we need to understand his emotions also, because whatever we communicate and or listen, so we need an empathetic mind, and we need to that. Convey that in an empathetic way. Okay, so what is empathetic way? Or how are we going to convey the message in an empathetic way? So there are a lot of things you can say, like, I understand your emotions. I know why you are hiding the truth. So that all things you can say to him, and then once you share these kind of empathetic words, definitely he will start to explore his emotions. So once he is able to explore his emotions, we can able to convey the importance of breaking bad news and all. So then you can able to break the bad news. So time up, we can wind up the session today. I think we need to discuss more this patient, because there are a lot of problems, physical problems, spiritual problems, and psychological problems. All together, there is this patient needed total care, but unfortunately, we don't have time now. That's why we were focusing on the collusion part only. Anyway, we have a good session today. Thank you, Rajika, for the wonderful session. Thank you, Lily ma'am, for the wonderful presentation. Thank you, everyone, for your contributions. See you. Thank you.
Thank you, Shivana, for this. I think that is wonderful. Thank you for that. Thank you, Lily, for the case presentation. Thank you, everyone. We'll see you in the next session.